2 hours, but now it's an IL. Actually, there's not much to cover lah. So I can do both lectures maybe in 1 hour or one hour plus lah. Okay. So the first lecture is on osteogenesis and bone growth. Okay, so by the end of this lecture, you should be able to describe the process of ossification and ossification centers. Oops. What's happening? Okay, sorry about that. I don't know what's happening, but hang on.
Doctor, try closing the window and reopening back.
Closing and opening Sekejap Okay, sorry about that technical difficulty. Okay, so by the end of the lecture, you should be able to describe the process of ossification and ossification centers, describe the process involved in the two types of ossification, describe the process of bone growth and remodeling and fracture healing. Okay, so what are the 4 types of bone cell? So before osteogenesis or ossification can happen, so you need to know what are the cells involved in the process of ossification or osteogenesis, meaning the formation of bone itself from what type of cells. Okay, so you have 4 types. The first type is your osteoprogenitor or osteogenic cells. So these are undifferentiated cells. So your precursor cells, and they can divide to replace themselves and can become osteoblasts found in the inner layer of periosteum and endosteum. Remember the periosteum? Periosteum is the outer covering of the bone, right? Okay, so this is where you find your osteoblast. Okay, so osteoprogenitor cells, when they differentiate into osteoblasts, osteoblasts form the matrix and collagen fibers, but they can't divide. Okay, and another type of bone cells is osteocytes. Okay, this is what makes up the mature bone tissue, bone cells or bone that make up the bone tissue. Okay, and osteoclasts are actually cells from fused monocytes or from the white blood cells. Okay, they serve to break down bone tissue and they function in bone resorption at surfaces such as the endosteum. Okay, so these are the 4 types of bone cells. You have your precursor cells or osteogenic cells, which then differentiate into osteoblasts. Okay, so osteoblasts, when they mature, they become osteocytes. Osteoclast is a different cell altogether because they come from monocytes. Okay, so what is ossification? It's actually the process of bone formation. It is also called osteogenesis. So osteogenesis and ossification is the same. Okay, what are the two types of ossification? First, we have intramembranous ossification, which is actually the formation of bone directly from fibrous connective tissue membranes. And we have endochondral ossification, which is the formation of bone from hyaline cartilage models. So in anatomy, if you find the word chondral or anything like chondral or chondro, something like that, it refers to cartilage. How osteo refers to bone, chondro refers to cartilage. So what is intramembranous ossification? Okay, so intramembranous ossification actually starts during fetal development in the uterus. It continues until adolescent period. At birth, the skull and clavicles are not fully ossified or not fully, and the sutures are not fully closed. I think I mentioned during the last lecture regarding sutures. Okay, so because the baby's head needs to pass through the small uterine canal or cervix to be born, so the skull is not fully attached, or the sutures are still open, so that it allows the head to be compressed during delivery. Okay, so intramembranous ossification is between the skull sutures, or between the bones of the skull, and they actually help the sutures to close and ossify the flat bones of the face. Okay, so so intramembranous ossification only stops at the end of adolescence, because actually the skull still keeps growing until the end of adolescence, where they stop growing, and that's when intramembranous ossification stops lah. Okay, so intramembranous ossification occurs only at certain areas of the body, so certain bones in the body. This includes the flat faces of the bone, the flat bones of the face, most of the cranial bones, and the clavicles, which are your collarbones. Okay, so only these bones, which are not a lot, only these bones are formed by intramembranous ossification. All the other bones in the body are formed by the next type of ossification, which is endochondral ossification. Okay, but we will just take a look at how intramembranous ossification occurs. Okay, so I'll show you the picture first because it's easier to see in the intramembranous ossification. So this is the 4 steps involved in intramembranous ossification. Hello? Okay, so during intramembranous ossification, the compact and spongy bone develops directly from sheets of mesenchymal or undifferentiated connective tissue. So the process begins when the mesenchymal cells in the embryonic skeleton gather together, and they begin to differentiate into specialized cells. So some of these cells will differentiate into capillaries, while others will become the osteogenic cells or osteoprogenitor cells, and then become osteoblasts. Although they will ultimately be spread out by the formation of bone tissue, early osteoblasts appear in a cluster called an ossification center. Okay, the osteoblasts then secrete osteoid or uncalcified matrix, which then hardens, and mineral salts are then deposited. Remember, in bone we have a lot of calcium, mineral salts deposited, and this will trap osteoblasts within the mineral salts. Okay, once the osteoblasts are trapped, they become osteocytes. Okay, so from osteogenic cells, they become osteoblasts. Osteoblasts then secrete osteoid, which is an uncalcified matrix around it. The calcium then comes in and calcifies the matrix. Okay, so once the matrix is calcified, the osteoblasts become entrapped, and they become osteocytes. Okay, so osteogenic cells to osteoblasts, then osteocytes. Okay, so osteoid, which is the unmineralized bone matrix secreted around the trabecular matrix, while osteoblasts on the surface of the spongy bone become the periosteum. So basically, the two parts of the bone become the osteoblasts in the two parts of the bone will become differentiate into different things lah. Okay, at the trabecular matrix they become osteoid, but at the surface of the bone they become periosteum. They differentiate to become part of the periosteum lah. Okay, then the periosteum capillaries will then create a protective layer of compact bone superficial to the trabecular bone. Remember parts of the bone. So on the outside will be the compact bone, and inside the long bone will be trabecular, where there are more spaces or empty spaces in between. Okay, so just to show you here, so there's about 4 steps. Okay, so the first part will be the osteoblast will gather in the center, okay, and secrete uncalcified bony matrix. Okay, and then the calcium will come in and calcify this bony matrix, okay, and the osteoblast become trapped in the center. So the trapped osteoblasts become osteocytes, okay, and then they differentiate into osteon at the, as mentioned here, okay. So in the trabecular matrix they become osteoid, and on the surface they become periosteum. So here you can see these cells have matured to become periosteum, and here they form trabeculae. Okay, and then blood vessels will come in and invaginate in between the trabeculae and provide more blood supply to this area. Okay, and the process actually keeps ongoing until the full bone of the skull is matured, okay, and has fused together until the end of adolescent period. Okay. So next is endochondral ossification. So if you see here, there are no involvement of cartilage. Okay, it's just directly from bone tissue differentiating into the two different parts of the bone lah. Okay, but here in endochondral ossification, because of the name chondral, so it involves the development of cartilage. So in endochondral ossification, bone develops by replacing hyaline cartilage. The cartilage itself does not become bone, but it becomes a template for which the bone is formed on. Okay, and then it completely replaces the bone tissues will completely replace the cartilage once it has done using the template. So the process is a bit longer than intramembranous ossification because it has to use this template, the cartilage as the template. And actually all the other bones apart from the bones mentioned in intramembranous ossification is produced or is formed by endochondral ossification. So in the long bone, for example, it takes about 6 to 8 weeks after conception. So in the uterus, about 6 to 8 weeks to for endochondral ossification to occur. Okay, so I'll show you the picture first. So you can see. So this is endochondral ossification, where we have chondrocytes to form a template, and finally be replaced by bone or osteoblasts and osteocytes. Okay, so so it starts at about 6 to 8 weeks after conception. Some of the mesenchymal cells differentiate into chondrocytes, meaning they start to form cartilage cells. Okay, so Soon after, the pericardium, a membrane that covers the cartilage, appears. So the pericardium is formed first. So more matrix is produced. The chondrocytes in the center of the cartilaginous model grow in size. As the matrix calcifies, nutrients can no longer reach the chondrocytes. This results in their death and the disintegration of the surrounding cartilage. Blood vessels invade the resulting spaces, not only enlarging the cavities but also carrying osteogenic cells with them, many of which become osteoblasts. These enlarging spaces eventually combine to become the medullary cavity. So as the cartilage grows, capillaries start to penetrate it and initiates the transformation of perichondrium into bone-producing periosteum. Okay, here the osteoblasts form a periosteal collar of compact bone around the cartilage of the diaphysis. By the second or third month of fetal life, bone cell development and ossification ramps up and creates the primary ossification center, a region deep in the periosteal collar where ossification begins. So if you see here, what this means is the chondrocytes start to grow cartilage in the center of the bone. Okay, and then newly derived osteoblasts cover the shaft of the cartilage, meaning the periosteum. The osteoblast starts to form the periosteum first. Okay, and then blood vessels start to penetrate in the cartilage in the center. Okay, and new osteoblast is brought by the blood vessel. Okay, and this forms the primary ossification center. Okay, so at the primary ossification center, bone tissue is produced, replacing the cartilage which was here. So the blue area is the cartilage and yellow is the bone tissue or osteoblast. Okay, so at the primary ossification center, after the blood vessel brings in more osteoblasts, so this will replace the cartilage template. Okay, and finally, at the end or diaphysis, a secondary ossification center. So the same thing happens. Blood vessels will bring in osteoblasts and form the secondary centers of ossification. And finally, the cartilage will be replaced by bone tissue or osteoblast. Okay, so the most important thing you need to know is that the difference between intramembranous and endochondral. Okay, so intramembranous is the direct formation of bone from osteoprogenitor cells. However, endochondral ossification involves the template or cartilage template, or the formation of the cartilage template before bone is formed before being replaced by bone tissue. Okay, so how about bone growth in length? So this is the actual start of formation of bone itself. So how does bone grow in length? Okay, so as I think I mentioned in the previous lecture regarding the epiphyseal plate. Okay, so if you look at the long bone, okay, we have what we call the epiphyseal plate near the diaphysis. If you see here, so this is the long bone, which is not fully developed yet. Okay, but we have this epiphyseal cartilage here between the metaphysis and diaphysis. Okay, so this epiphyseal cartilage will allow the bone to grow in longer Okay, so this epiphyseal plate or cartilage is the area of growth in a long bone. This is the only area where where it permits the length of the bone to grow. Okay, it is a layer made of hyaline cartilage where ossification occurs in immature bones. So on the epiphyseal side of the epiphyseal plate, cartilage is formed. On the diaphyseal side, cartilage is ossified and the diaphysis grows in length. The epiphyseal plate is composed of 4 zones of cells and activity. So between the age of 18 to 25, the epiphyseal plate closes. the cartilage cells stop dividing and bone replaces the cartilage or epiphyseal line. Okay, so this at the age of 18 to 25 is when you stop growing in length because of the union of the epiphyseal plate. So if you imagine when you were born, the epiphyseal plate or cartilage is still made of chondrocytes or cartilage, hyaline cartilage, so it can still grow in length. However, at the age of 18 to 25, this cartilage will be replaced by bone completely, and you will stop growing because there is no more epiphyseal cartilage or plate. Okay. So what are the 4 zones of the epiphyseal plate? So if you imagine we cut through or we focus or zoom in to the epiphyseal cartilage, we will find 4 different zones of the activity lah. Okay, going on. So zones of the epiphyseal plate. First is the proliferative zone. Okay, this is the next layer towards the diaphysis and contains stacks of slightly larger chondrocytes. It makes new chondrocytes via mitosis to replace those that die at the diaphyseal end of the plate. So if you imagine this is at the diaphyseal end, so the uppermost here would be your proliferation zone lah. Okay, so next going downwards, you'll find your zone of maturation and hypertrophy. So proliferative is when a lot of new chondrocytes is produced to replace the via mitosis lah, to replace the ones that die. Okay, and then next layer, they mature and hypertrophy, they become larger. Okay, the longitudinal growth of bone results in cellular division in the proliferative zone and the maturation of cells in the zone of maturity and hypertrophy. Okay, so once they are matured, they become calcified. Okay, because the capillaries and osteoblasts from the diaphysis penetrate this zone, and the osteoblasts secrete bone tissue on the remaining calcified cartilage. Thus, the zone of calcified matrix connects the epiphyseal plate to the diaphysis, a bone growth in length when osseous tissue is added to the diaphysis. So bones continue to grow in length until adulthood. The rate of growth is controlled by hormones, which will be discussed later. So when the chondrocytes in the epiphyseal plate cease their proliferation and bone replaces the cartilage, longitudinal growth will stop. So all that remains of the epiphyseal plate will be the epiphyseal line. Okay, so this is what happens when the growth is stopped lah. Okay, so you'll see here, these are your 4 zones lah. Okay, so if you do a cross section here of the epiphyseal plate, you can see the white area in the middle. Okay, so if we zoom in, this is what we will see, the 4 zones of the epiphyseal plate. So this is the diaphysis here lah. Okay, so the first zone will be your proliferation zone. As the name suggests, there is proliferation, okay, of chondroblasts. So again, this will use the intrachondral ossification. The chondroblast will start to create template first, okay, and then be replaced by bone tissue. Okay, so chondroblasts or precursor cells for cartilage will divide and push the epiphysis away from the diaphysis, lengthening the bone. Okay, because of the rapid mitosis, it will push away the diaphysis from the epiphysis or metaphysis here lah. Okay, so after the proliferation or mitosis, the cells will become the chondrocytes will become hypertrophied. Okay, they enlarge, and then later in the third zone they become calcified. Okay, and the matrix will become calcified, and then the chondrocytes will die off, leaving trabecular-shaped calcified cartilage. Okay, but no bone cells is yet produced. Only calcification happens and the death of chondrocytes. At the ossification zone, as the name suggests, this is where your osteoclasts digest the calcified cartilage and osteoblasts replace the cartilage with actual bone tissue in the shape of the calcified cartilage. Okay, this will result in the bone trabeculae, the spongy bone trabeculae. Okay, so how does bone grow in thickness or diameter? So this is how it grows in length by having the epiphyseal plate and chondroblast eventually being replaced by bone tissue. So how does it grow in thickness or diameter? So although the growth in length stops or ceases until about 18 to 25 years old, the bone can still continue to grow in thickness or diameter. Okay, so a lot of activities such as exercise and so on can help to grow your bone in thickness or diameter. Depends on how much you're using your bones. Okay, so this is called appositional growth or growth in thickness or diameter. Okay, so osteoclasts resorb all bone. What's this? Allow. That lines the medullary cavity, while osteoblasts via intramembranous ossification produce new bone tissue beneath the periosteum.
Sir,
Yeah.
can you listen? Sorry. Can you please put in full screen because the wordings are a little small for us.
Oh, you're not using your laptop, is it?
No, it's what they call it. You're not in full screen. I can't see just now the diagram, right? The small wordings all can't be seen.
How come it's small? Are you not using your laptop?
I am.
Oh, so it's small even in your laptop, eh?
Yeah.
Okay. Because because just now it hangs when I open the full screen. That's why I use the small. But it's okay lah. I hope it doesn't hang anymore. Okay. So where was I? So bone growth in thickness or diameter is called appositional growth. Okay, so osteoclasts resorb old bone that lines the medullary cavity, while the osteoblasts through intramembranous ossification produce new bone beneath the periosteum. So the erosion of old bone along the medullary cavity and the deposition of new bone beneath the periosteum increases the diameter of the diaphysis and also the diameter of the medullary cavity. And this process is called remodeling. Okay, so this is what it means. Okay, so ridges in the periosteum create groove. They create groove for periosteal blood vessels. Okay, and then the ridges will start to fuse and form like a tunnel, endosteum lined tunnel. This is all an endosteum. If you imagine, this is the trabeculae in the middle of the bone, and then they start to form ridges around a blood vessel. Okay, and the ridges will then fuse to form a tunnel. Okay, then the osteoblasts in the endosteum will start to build new concentric lamella inward towards the center of the tunnel, forming a new osteon. So this whole new unit is called the osteon. Okay, the tunnel that is formed will form is an osteon. Okay, and osteoblasts will be secreted to form bone towards this center lah. Okay, and layers and layers of bone will develop around the artery, and the development of these bones or osteons will cause the bone to be thicker or larger in diameter. Okay, so Remodeling is the ongoing replacement of old bone tissue by new bone tissue. So the old bone is constantly actually destroyed by osteoclasts, whereas new bone is always constructed by osteoblasts. So there's some hormones and calcitriol that control bone growth and bone remodeling. So it is an ongoing process because the osteoclasts will ongoingly carve out small tunnels and the osteoblasts will rebuild the osteons. So osteoclasts form leak-proof seal around the cell edges that secrete enzymes and acids beneath themselves, releasing calcium and phosphorus into the interstitial fluid. The osteoblasts will take over and then rebuild the bone at the area lah. Okay, so continual redistribution of bone matrix along lines of mechanical stress. For example, the distal femur is fully remodeled every 4 months. Okay, so what this means is that although we don't have bone growth in length anymore, bone remodeling or bone growth in diameter happens until now um, because of the mechanical stress that is put on bones. We need to have it remodeled every now and then. So for example, the distal femur, it is actually our distal femur is remodeled every 4 months. So meaning because of wear and tear of usage of, because we use bone every day, right, in our movement. Okay, so because of that, it creates some mechanical stress on the bones. So for example, in the femur, so osteoclasts will always come and carve out the area that has undergone stress. Okay, just small areas or thin surfaces on the surface of the bone. Okay, and the osteoblasts will start to remodel or start to build new bone around the area to replace the area that has been carved out by the osteoclast. Okay, and this process is called remodeling of the bone every 4 months. So this ensures that our bone stays healthy and are constantly being remodeled lah. Okay, so what are the factors that affect bone growth? First, of course, nutrition. So you need to be able to ingest or have adequate levels of minerals and vitamins. So calcium and phosphorus, vitamin C, vitamin K, and B12, of course, they all help in bone growth. The main part of the matrix of the bone is, of course, calcium. That's why you always hear from childhood that milk is good for you because of the calcium, right? Actually, it is good because it forms part of the matrix of the bone. Okay, sufficient levels of hormone as well. So we have hormones like your growth factor hormone and thyroid hormone, and insulin also helps in bone growth. So, but you will learn all this later in physiology, how they actually, what's the process involved lah. Okay, so hormones at puberty such as estrogen, testosterone also helps to stimulate sudden growth. If you notice nearing puberty, usually male especially, they suddenly shoot in height, right? So I'm sure you've come across like a boy in class who was very small, but suddenly around puberty he shoots up and becomes suddenly tall, right? Okay, that is because of the surge of hormones such as testosterone during puberty that causes the sudden growth lah. It stimulates the growth of the epiphyseal plate. Okay. So growth, just a bit on growth hormone. So it is secreted by the anterior pituitary to regulate and regulated by the hypothalamus. Okay. It is regulated by a lot of regulatory factors such as GHRH, somatostatin, ghrelin, and insulin-like growth factors. Okay. So the principal physiological regulation of GH are neural endogenous rhythm, sleep, stress, exercise, and nutritional and metabolic signals. So all this is important for growth. Okay, so like your sleep, less stress, more exercise, good nutrition, they all have an impact on bone growth. Okay, so the deficiency of this hormone or too much of this hormone can cause problems. So for example, oversecretion, if there's too much growth hormone, it causes gigantism, and too little or maybe thyroid hormone problems will cause dwarfism. Okay, so if you see here, this is the an example of gigantism. Okay, so this man has hypersecretion of growth hormone, causing him to be very tall, extra tall, and hyposecretion, so not enough growth hormone, causes dwarfism. Okay, so last but not least, just a bit on bone fracture. So how does bone heal when it after a fracture? Okay, so healing in bone is actually faster than in cartilage because there's more blood supply in the bone as compared to cartilage. So healing of bone, however, is still slow as although it's faster than cartilage, but it is not. It is still a slow process if there is vessel damage. Because the vessel is what helps the healing to be fast. Okay, but if the vessel involved is damaged, then it will take a long time to recover. Okay, so what are the clinical treatments that we have? Open and close reduction, which you will learn more in detail when you do your surgical posting. Okay, just to introduce you to the terms. Okay, so close reduction, where you restore pieces of the fracture by manipulation, so you don't need surgery. Open reduction means you need to open up and do surgery to replace or restore the bone into its normal position. Okay, so how is the repair of a fracture? What is the process involved? Okay, so first, a formation of hematoma. Hem in anatomy or in medical, as I mentioned, osteo means bones, chondro refers to cartilage, so hem refers to blood. Okay, so if you have hemangioma, for example, is blood cancer or blood tumor. Hematoma is formation which hematoma is like this. So accumulation of blood. Okay, so damaged blood vessels produce clot in about 6 to 8 hours and will cause the bone cells to die off. Okay, because of the lack of blood vessels lah. Okay, so inflammation brings in the phagocytic cells for cleanup duty. So the phagocytic cells will clean up the debris from the fracture. So the small bits will be cleaned up by phagocytes. And then new capillaries will start to grow into the damaged area because of the damaged blood vessels during the fracture lah. Okay, so after that, there will be a formation of the soft callus, which is fibrocartilaginous, because the fibroblast will come and lay down the collagen fibers. The chondroblast will produce the cartilage part lah. Okay, to span the broken ends of the bone. Okay, finally, this fibrocartilage will be replaced by hard callus, which is osteoblast. They start to secrete spongy bone to join the two broken ends of the bone. This can last for about 3 to 4 months. And bone remodeling. Finally, bone remodeling happens where the compact bone replaces the spongy bone in the bony callus. So if you look at this, okay, so first hematoma is formed, okay, and here the new blood vessels is formed, and there is cleanup duty by the phagocytes. Okay, next, so the formation of new blood vessels and this is the debris. So this will be cleaned up by phagocytes lah. Okay, and then spongy bone will be formed in between the two. Fibrocartilage is formed first, okay, and then this will be replaced by bone in the soft callus first, and then bony callus, okay, and then this will mature into our normal type of bone lah, and restructure or realign back together after many months. Okay, I think that's all for this lecture. Shall we continue with the next lecture, or do you want 5-minute break before we start?
I think we can continue, Doctor.
Continue,
Yes.
Okay, so the next lecture will be on arthrology. Right, can you give me 2 seconds? Okay, so arthrology. So today a lot of new terms for you. So osteobone, chondro, cartilage, heme is blood. Okay, so for arthro is always referring to joints. Okay, that's why arthritis is disease of the joint. Arthrology is the study of joints. Okay, so from this lecture you should be able to then describe the type of joints with examples, describe the structure of a typical synovial joint, describe the different types of synovial joint, and describe the neurovascular supply of the joints, and relate the anatomy of the bursa. You learn about the bursa as well, and relate it with relevant clinical conditions. So what is a joint? A joint is a union or junction between two or more bones of the human skeleton when they are fit together. Some joints have no movement, such as the epiphyseal plate of a growing long bone. We just learned about that. Remember the epiphyseal plate, because the epiphyseal plate is cartilage, it's made of hyaline cartilage. Some anatomists still consider it as a joint because it joins the diaphysis to the metaphysis, right? Okay, so by definition, it is still classified as a joint lah. However, there is no movement at the joint because it is only for growing of the long bone. Okay, some joints are freely movable, such as the shoulder. So a lot of movement happens at your shoulder joint. Some joints only permit flexion and extension, for example, at your elbow. Okay, so how do we classify joints? There are 3 classes according to the type of material where the bones of the joint articulate or unite. So for example, here these are two bones, and this area here, or the joint here, are united by this synovial cavity. Okay, so this is the synovial joint where bones are united by a layer containing synovial membrane and fluid. Okay, so next is fibrous joint. As the name suggests, it is connected by, the bones are united by fibrous tissue. Okay, so for example, here we have syndesmosis, which is here the example is interosseous membrane. You can find this interosseous membrane between your ulna and radius. Okay, and your sutures are also considered as a fibrous joint because you have fibrous tissue in between the sutures. Okay. And the third type is cartilaginous joint. As the name suggests, it is joined by cartilage. Okay, and the cartilaginous joint is further divided. Okay, the first type is primary. Wait, can you give me 2 minutes?
Doctor, no problem.
Okay, so the first type is the primary cartilaginous joint, where the bones are united by hyaline cartilage and allows slight bending during early life. So this is the epiphyseal plate, which I mentioned earlier. There is close to no movement, just maybe slight bending can occur, but very slightly, like you can't even see it from outside. Okay, so this is a temporary union, as I mentioned. At the age of 18 to 25, there will be full closure of this epiphyseal plate. Okay, this is an example of the primary cartilaginous joint. For the next type of cartilaginous joint is the secondary cartilaginous joint. Okay, and this can be found in the intervertebral disc, the disc between your vertebra. Okay. Okay, the next type of joint is your so we'll talk more about the synovial joint. So we've mentioned here we have cartilaginous, which is joined by cartilage. We have fibrous, which the bones are joined by fibrous tissue, and we have synovial joint, where there is a synovial membrane inside. Okay, so we will talk more on the synovial joint, as this is the most common type of joint found in our body. Okay, and they provide free movement between the bones that they join. Okay, they usually, because of the free movement, they have ligaments to help support the joint so that it doesn't become dislocated. So for example here, this is an example of a synovial joint between your head of femur and pelvis. Okay, so as I mentioned, they have ligaments to support, which are extrinsic and intrinsic. So intrinsic ligament is the thickening portion of the joint capsule itself. And the extrinsic are joints at the outer parts of the coming from elsewhere lah. Okay, supporting the joint. The more movement at the joint, or the more movement that the joint enables, the more ligaments there is lah, okay, to prevent it from dislocating. Okay, so some synovial joints have distinguishing features such as fibrocartilaginous. They have articular disc or meniscus. Okay, but as a whole, these are the three main features of the synovial joint that you need to know lah. Okay, it has an articular capsule, articular cartilage, and synovial fluid. Okay, so first we will talk about the articular capsule. It surrounds the joint and is continuous with the periosteum of the bones articulating it lah. Okay, so it consists of two layers, the outer fibrous layer and the inner synovial layer. Okay, so the outer fibrous layer consists of white fibrous tissue known as the capsular ligament. It holds together the articulating bones and supports the underlying synovium. The synovial layer is highly vascularized layer. It absorbs and secretes synovial fluid and is responsible for the mediation of nutrient exchange between blood and joint, also known as synovium. So as the name suggests, the synovial layer inside is what secretes and absorbs synovial fluid. This will create nutrient exchange. There is no, inside the cavity, there is no direct blood supply. So the nutrient is received from the synovial fluid, bringing in the nutrient to the joint. Okay, so this is what the articular cartilage looks like. Okay, so you have two layers of the articular cartilage, and this is the capsule, and inside the articular cavity or joint cavity we have synovial fluid being produced by the cartilage. Sorry. Next is the articular cartilage, which is this blue area here. Sorry, we just now we talked about the capsule. Okay, you can see here fibrous layer and the inner synovial layer. So this synovial layer is what produces the synovial fluid. Okay, so now we'll talk about the articular cartilage itself. Okay, so they're just articulating surfaces of the synovial joint covered by a thin layer of cartilage. So the main role is to minimize friction of the joint and also to absorb shock. Okay, the articular cartilage is avascular, so it doesn't have its own blood supply, and it receives nutrient from diffusion from the synovial fluid, because synovial fluid contains nutrient. So the nutrient from the synovial fluid will supply the articular cartilage. So if you see here, this is the cartilage here in the middle, so it doesn't have any blood supply, direct blood supply. So synovial fluid from the articular capsule will help to provide nutrient to this area lah. Okay, so synovial fluid is located within the joint cavity of a synovial joint. The three main functions are for lubrication, nutrient distribution, and also shock absorption. Types of synovial joint. So the synovial joint is further divided into 6 types according to their movement. Okay, so the first type is the plain synovial joint. So in the plain synovial joint, there is only gliding movement that can occur. Okay, so very little movement, only gliding. So this is, for example, at the acromioclavicular joint. So the acromioclavicular joint is between the scapula. So this is your scapula, and this is your acromion process of the scapula. So between that and the clavicle is a plain synovial joint where only gliding or sliding movement is allowed. Okay, next is the hinge joint. So at the hinge joint, the movement that can occur is only flexion and extension. Okay, so the movements occur in one plane around a single axis. Okay, so for example, here is the elbow joint. You can only have flexion and extension of the elbow joint. Next is the saddle joint. Okay, it allows more movement. Okay, it permits abduction, adduction, flexion, and extension. So movements occur around 2 axes at right angle to each other, so that it is biaxial joint. Biaxial means 2 axes. Okay, so also it allows movement in circular motion, which is circumduction. So for example, your carpo-metacarpal joint. So these are your carpal bones here, and this is your first metacarpal. So the joint between your carpal bone and metacarpal is called your carpo-metacarpal joint. Okay, so this carpo-metacarpal joint allows abduction, adduction, flexion, extension, and also circumduction. You can also do circular movements with your fingers. Next is the condyloid joint. So it allows flexion and extension as well as abduction and adduction. Okay, so movement is through one plane, through the sagittal plane, and usually greater and freer than other. However, circumduction is more restricted. So the main difference between saddle joint and condyloid is circumduction. So for example, here between your metacarpal and phalanx. Metacarpal is your is the bone that makes up part of your hand. Okay, and phalanx is your fingers. Okay, so here metacarpophalangeal joint, you can do flexion, extension, and you can abduct and adduct, but you cannot do circumduction with the joint. Okay, you can try all these movements. Okay, next is ball and socket joint. This type of joint allows permits a lot of movement, probably the most movement compared to all the other joints. Okay, so because movement can happen in multiple axes and planes, they can perform flexion, extension, abduction, adduction, medial and lateral rotation, and circumduction as well. So it is called a multi-axial joint because it can move in many axes. Okay, usually the one bone has a spheroidal surface within which moves within the socket of another, so it's called ball and socket. So for example here, the head of femur acts as the ball and the socket is acetabulum of the pelvis or hip bone. Okay, so ball and socket joint. Another example is the shoulder joint, okay, which the head of humerus also connects with your scapula. Okay, next is your pivot joint, which allows only rotation. Okay, so this is quite specific because we don't have many pivot joints in the body. Okay, it allows only rotation in one axis. Okay, so for example, is at the median atlantoaxial joint. The atlas is actually C1 or your first vertebra, and the next vertebra, your C2, is called the axis. So between the atlas and axis, you have the atlantoaxial joint because the axis has this projection, this dent, which helps it to be able to helps the atlas to rotate around it like this. Okay, so this allows your head to be rotated. So you can rotate your head because of atlas and axis or atlantoaxial joint. Okay, so just to show you in a summary here, so you have your atlantoaxial joint here, which allows movement, rotation movement only. Okay, and you have your pivot joint, which is your pivot joint lah. Okay, which allows uniaxial rotation movement. And here at your shoulder joint, this is a plain synovial joint which only permits slight gliding or sliding movement, which is at your acromioclavicular joint here. Here in your elbow, remember, you can only have flexion and extension, and that is the hinge joint. And here in your hands, so between your carpal bones and your metacarpal, so carpal metacarpal, you have a saddle joint. Okay, and here between your metacarpal and phalanx, so metacarpal phalangeal joint, it is a condyloid joint. So the difference is circumduction. Here you have more circumduction. Here you have limited range of circumduction, or sometimes no circumduction. Okay, and the most the joint that allows most movement is the ball and socket joint, which is here, for example, at the hip joint, and also actually at the shoulder joint also we have ball and socket joint. So how about joint vasculature? So how does the joint receive blood supply? Okay, it receives blood supply from arteries supplying the bone next to it. Okay, so the arteries anastomose, or they communicate with each other to form networks of periarticular arterial anastomosis to ensure enough blood supply to the joint. So if you see here, this is the artery supplying this part of the bone, and this is the artery supplying the other end of the joint, which is the bones here. Okay, so they will anastomose or communicate with each other, and finally give off blood supply to the joint area lah. Okay, again here, so here you can see this is the shoulder joint, this is the brachial artery supplying the humerus, and this is the subclavian giving off the axillary artery. Okay, supplying the scapula. Okay, because so they will eventually anastomose and give off blood supply to the joint here, which is your shoulder joint. Okay, the veins accompany the artery. So where there is the artery, the veins accompany them, and they are called vena comitantis. Okay. So next is the innervation of the joint. So how does the joint receive nerve endings? Okay, again, similarly, the nerve that supplies the bone of the joint will give off branches inside the joint area lah. Okay. So this is also called as the Hilton law, which the nerve supplying a joint also supplies the muscle moving the joint and the skin covering their distal attachment. This basically just means that the joint receives nerve supply from the nerve that supplies the muscle and bones next to it lah. Okay. So in terms of joint stability, it refers to the resistance offered by various musculoskeletal tissues that surround a skeletal joint. Instability of the joint can cause unhealthy range of movement in your joints, which may result in the joint fractures. So what are the factors that contribute to the joint stability? Number one, the shape, size, and arrangement of the articular surfaces. So for example, at the shoulder joint, the humeral head is disproportionately larger than the glenoid fossa of the scapula here. Okay, so the joint is a bit unstable because there is less contact between the two surfaces, meaning the head is big as compared to the fossa itself lah. Okay, so a lot of the part of the head is not inside, it is not connected or in contact with the glenoid bone, so it becomes less stable. So however, as compared to the pelvis or the hip joint, the head of femur is fully enclosed by the acetabulum of the pelvic bone. Okay, so this makes the hip joint far more stable as compared to the shoulder joint lah. Okay, so one factor is the shape, size, and arrangement of articular surfaces causing joint stability. Next is ligaments. Okay, so ligaments of the joint prevent excessive movement that could eventually damage the joint. As a general rule, the more ligaments, the tighter the joints are and the more stable. So next is the tone of the surrounding muscles. Okay, the muscles surrounding the joint also helps to stabilize the joint. Okay, another structure that you can find in the joint are the bursa, the synovial membrane and bursa. Okay, so the synovial membrane lines the capsule and is attached to the margin of the articular surface. On the front and above the joint, the synovial membrane forms a pouch, which is the bursa, which extends up beneath the quadriceps femoris muscle. So actually the bursa is an extension of the synovial membrane out of the synovial cavity. Yeah? So you can see here, we have at some areas where there is a lot of, where it needs cushioning at the joint, we have bursa which acts as a cushion to protect the area. So for example here, this is the knee joint, okay, and this is where you find the bursa. It acts like a knee pad or like a cushion to help reduce friction at the area. So you have 1, 2, 3, 4 bursa at the knee joint. Okay, so what are bursa? They are fluid-filled cavities located at tissue sites where tendons or muscles pass over bony prominences near joints such as the knee. So example here, you have your quadriceps femoris muscle, and this is your patella, which is bone. Okay, so in order to reduce friction between this quadriceps muscle and the bone, which is the patella, we have the prepatella bursa. Okay, and also here we have the femur, and so between the femur and quadriceps as well, we have the suprapatellar bursa to help cushion this area to reduce friction lah. Okay, because there's a lot of movement happening at the knee joint. And here as well, we have bursa around the knee joint. Okay. Next structure that we can find is tendon sheath. Okay, so all these are actually extensions of the synovial membrane. Okay, it contains synovial fluid. So bursa is one structure that contains synovial fluid, and it is extended around areas to facilitate movement and reduce friction. Next, we have tendon sheath, which is again a synovial membrane around a tendon. So here in the hand, for example, we have tendons of muscles in the arm. Okay, and these tendons attach to the phalanx, okay, or your digits. So around the tendon, we have what is called a tendon sheath, covering the tendons to reduce friction again, to allow movement or stretching of the tendons and facilitate movement lah. Okay, so it has two layers, the synovial sheath and the fibrous tendon sheath. Okay, so what are the clinical correlates that we can look at into? So first, osteoarthritis. So as I mentioned, arthri would be referring to joints. So we have many types of arthritis, which is disease of the joint. The first is osteoarthritis. I think this is the quite common in the elderly. Okay, the most common form is the hip arthritis of the osteoarthritis lah. Okay, it is a chronic condition characterized by breakdown of cartilage that cushions the ends of the bones where they meet to form the joints. So it is actually damaged articular cartilage, okay, due to wear and tear of the cartilage. So for example, here in hip osteoarthritis, which is quite common in the elderly, the articular cartilage here is damaged, okay, causing the bones to rub against each other. Okay, they also have less fluid, articular fluid inside, synovial fluid inside the joint. Okay, and this causes pain, stiffness, loss of movement, and formation of bony overgrowth or spurs. Okay, so the next type is rheumatoid arthritis. This is caused by an inflammatory disease. So in osteoarthritis, actually there's no inflammation going on, only breakdown of the cartilage, the articular cartilage here, due to wear and tear. Okay, that's why it's more common in the elderly. For rheumatoid arthritis, actually, the body's own immune system attacks the synovial membrane. So there is some inflammation going on. So the cartilage is damaged, but due to our own body system attacking it. So because there is inflammation, there is also redness and swelling and warmth at the affected joint. Okay, so if you imagine this is a normal type of joint, okay, and this is rheumatoid arthritis, they have inflammation. Okay, and also because of the attack from our own immune system, it attacks the cartilage and causes pain lah in this area. Also, there is reduced joint space because it also attacks the synovial fluid. Okay, so in the rheumatoid arthritis commonly occurs more in the knees, hips, hand, wrists, feet, elbow, and ankles. Okay, next form of arthritis is juvenile arthritis. As the name suggests, it is for children lah. It is the disease in the children, but the cause is usually unknown. Similarly, with rheumatoid arthritis, it can be genetically inherited, but mostly we don't know. With autoimmune disease, we don't know the cause. Okay, it just some people the body's immune system can attack the normal body system. Okay, so next is ankylosing spondylitis. Okay, so in this type of arthritis, it only affects the spine. Okay, so what happens is, again, it is inflammation. So the cause of inflammation is unknown. It's called autoimmune. If you've heard of autoimmune disease, there's a lot of autoimmune disease out there where our own immune system attacks our body, our own healthy body. So in this case, it attacks our immune system, attacks the spine. So and this causes the vertebra to fuse, or the discs to be smaller, and finally fuse together. And this in return, it shortens the spine or causes deformity of the spine, and this is called ankylosing spondylitis. Okay, next is gout. I think you've heard of gout, right? Okay, so if you eat too much, if you ingest too much iodine, okay, the iodine can be sometimes deposited as uric acid crystals in the joints. Okay, usually is the big toe lah. This is the most commonly affected joint, where they get swelling of the big toe in gout. Okay, what else? Subsequent attack, people with gout comes with pain in the foot or knee, but usually the most commonly, as I mentioned, is the big toe of the foot lah. Okay, this is the most commonly affected area. So due to the formation of uric acid crystals inside the joint, and that causes the pain and inflammation lah. Okay, so this is mainly due to diet lah. Okay, next is infectious arthritis or septic arthritis. As the name suggests, infection inside the joint. Okay, usually because remember, the blood supply comes from the adjacent or next bones beside it. Okay, so any inflammation around the area can be brought by the blood into the joint cavity as well. Okay, and because of that, this can cause septic arthritis or infectious arthritis. Okay, so I think that's all for this lecture. Thank you very much. Also, can you take attendance now for both lectures? Can someone share the link of the attendance here in the chat? Okay. Oh, okay. So, attendance for GA06 and GA08. Make sure you choose the correct class and correct lecturer. Okay, thank you very much. I will look into the attendance at the end of today and give a summary lah. Okay, thank you very much.